from. So let us just go a little, part of uh, to understand the basic concepts. Then we can even understand our case, which is going to be discussed on Thursday. And we try to form a mind and make a format of the liver diseases as such. And inshallah, when I finish this, and I told that there's an additional supplement which I'm putting in this to today's PowerPoint lecture. And if you want, I'll send it to the Hadil and you can take it from her. And that is a supplement not for the exam, but for understanding of the liver diseases, basically. So, this most important is not the exams. The most important is of your career to pass the SMLE exam, of course, with very good marks. And of course, people will be becoming a resident. So the basic concept of medical college over here is to understand the disease at the level of etiology and pathogenesis. That is the causes and how the sequential steps of formation of a disease pathologically. And if you don't understand this, even you don't understand the anatomy properly, the physiology, as well as biochemistry, the basic sciences, then if you go to the clinical side, next year you'll have total jumble and you'll be confused totally. So I always tell my F13 and F16 female students to make a conceptual approach to all the disease, especially in the nutrition metabolism and what we have tried to do in the mind and movement also. So with these few words, I'll just go fast in this particular PowerPoint which I have given, and then I come back to it after giving your supplement of understanding of the disease of the liver. That is, will be taking only the 3 diseases as such, but you have a lot of time, and I'll try to give Hadil or our Jomana or Batul a PDF from the Big Robin such that you people can read it. So with these few words, I'll just start off. So basically, intended learning objectives for today's practical is very simple. We are going to discuss the fatty changes in liver, most probably due to alcohol. Okay. And we have, other than that, we have a fatty change, and you just take a ultrasonography of our parents totally. And I think here in Saudi Arabia or India or anywhere, and especially in developing countries, what is happening is 40 to 60% of the people are having fatty changes in the liver. But here we'll try to study the alcohol for the sake of examination. Then we'll go try to look for the chronic hepatitis. Our Ibrahim, the case number 5, had chronic hepatitis with a very tricky trigger analysis, and we have to really come to a conclusion in the second session and how we can discuss the markers. And today is not the day to discuss it. So this is the one. And the third one, of course, the final end-stage liver disease called cirrhosis of liver, and that will be for your examination. So 1, 2, and 3 are the intended learning objectives for this one. And I'll go into more detail in my supplement about the normal liver, which is divided into the different lobules. You can see over here with a central vein, or you can see over here, this area. This is central vein, basically, which lacks a little decrease in the blood supply. So the periphery of the lobule are the portal tracts. This is basically a portal tract, which we ought to understand. Functioning the liver can be divided into 3 zones. Zone number 1, 2, and 3. The zone number 1 near to the portal tract, which has a lot of good oxygen supply because of the better blood supply. The zone number 1 encircles the portal tract with oxygenated blood from the hepatic arteries, and zone number 3 is near the central veins, where oxygenation is little less. It's not completely absent, but little less. So we can call it oxygenation is poor. Okay, this is very important to understand. Zone number 2 is located in between. So these are basically the lobules. You can see over here the lobules over here, and this architecture is maintained. You can have a central vein over here, and this area is zone number 3, 2, and 1, like that. Okay, we go furthermore. This is actually the lobule which I have circled over here in a hexagonal fashion. And you can see over here again the portal tract, and the yellow line with that, what do you call it, the central vein. Okay, the liver lobules have the two blood supplies to the liver is 80% from the portal tract. So this is the MCQ which can come in the examination, and hepatic artery is only 20%. So the portal tract, deoxygenated blood from the GIT tract is actually given by the portal veins. Now, this is very important to understand the portal hypertension. Today is not the theoretical class, but I'm trying to give you some idea about what do you call it, the basic understanding of the approach toward liver disease. Okay, hepatic artery is only 20%. So one drainage vessel, hepatic veins, carry processed blood away from the liver. There's only one vessel which has going off, and another is the bile duct. So we have a artery, we have the vein, we have the bile duct in the portal tract. Okay, and you should know anatomically what is portal tract, and you should know portal hypertension. Okay, now these are basically the liver zones. You can see over here the zone number 1, which is actually, this is basically present in the portal tract, which has a portal vein, which is a bile duct, and a hepatic artery. And people who are interested in pathology can take the residency in pathology. If I'm alive, I can teach you such that I get a lot of ajr. This is zone number 1, and zone number 2 is mediocre, and zone number 3 is near the hepatic vein. Okay, little deoxygenated. So this is called periportal area. This is called mid-zonal area, and this is called centrilobular area. Now these istilahat, we call it terminologies, should be remembered by you to understand the PubMed articles as well as the Robbins. Please read Robbins. I've given to my F13 and F16 people the 10th edition or the 11th edition basic Robbins, and the big Robbins called 10th edition. I try to give you some PDF from that one. The liver zones are on zone number 1, which is having a good blood supply. It's called periportal area. Now, this is affected by viral hepatitis first. And this is again an MCQ which can come in the examination. We can ask you even in the practicals. Zone number 3, centrilobular in the central vein. This furthest from the blood supply, so decrease in oxygenation over here. Comparatively, this is most vulnerable to ischemic diseases, ischemia, So fat accumulation begins here in the alcoholic liver disease. So alcoholic liver disease starts in zone 3. Viral hepatitis starts in zone 1. Now, these are the MCQs, which I myself, if they allow me to give the question, I'll be putting it like that. So high concentration of P450 enzymes in hepatocytes is very important for you to understand the drug metabolism, which we actually eat. Like we eat a lot of Panadol daily, and we eat some, sometimes in rheumatoid arthritis, we eat methotrexate, and there are hundreds of drugs which affect the liver and causes liver cell injury. Okay. Now, these are basically the synthetic functions of a liver, and the liver has the potential of removing the toxic substances as byproducts of certain medication. I told you it has a potential of dealing with the medications. It prevents shortages of nutrients, storing a lot of vitamins, and store a lot of vitamin, minerals, and sugars. So you should be very thorough with the biochemistry of the liver function. That you can even read from a biochemistry book, or you can even read from Guyton. And it metabolizes or break down nutrients from the food to produce energy when needed. So it produces most proteins needed by the body. It's like a factory. It's a shirka. Helps your body fight infection by removing bacteria from the blood. It produces many substances that regulate blood clotting. So many of the blood coagulation factors in the form of proteins are being produced over here. It produces bile, a compound needed to digest the fat, and absorbs ADEK, the fat soluble vitamins. It's very important. So what is important is to understand the bilirubin metabolism. Inshallah, I'll try to tell you today very fast, but go and read it in detail. So this is basically the portal tract over here. You can see the portal vein, the hepatic artery, and the bile ducts very clearly. And these little cells, Usamma stellate cells, they are very important for formation of, they are very important for formation of fibrosis. Okay, sorry, again, this affecting. So this is the stellate cell, basically very important. And this particular area is called space of DC. Can you see the screen?
Yes, doctor.
Yeah. So this is basically the space of DC. You should know it. And the Kupffer cell mechanism is very important to understand the reticuloendothelial system. So this basically we are dealing with that. So the fatty changes of the liver, I'll just come back to it after reading the supplement, just for the sake of examination. In the examination, we'll ask you if I put this diagram to you, what is the organ? It's very easy, the liver. It's slightly enlarged, of course, showing a yellow appearance in the fatty changes of the liver. Mostly when you think of the fatty change, don't think of we eat a lot of mandi, roast bukhari, or hakada, but we have to think in favor of the alcoholic liver disease, which is so common in the Western world. They don't drink water much, but they try to drink alcohol much. As we drink water less over here, we try to drink Pepsi over here much. So these are the areas where the liver shows fatty changes. So when you cut the surface, it becomes greasy, yellowish appearance seen on the capsule as well as on the top and the cut surface. This uniform change is consistent with the fatty change. I have done a lot of autopsies during my residency program, maybe around 500, and I've seen a lot of fatty changes. So how to describe a liver? They might ask you, but it's very easy. Refer to the pathology workbook. It's written there. What is the shape of the liver, the size of the liver, the color of the liver, yellowish, greasy touch, outer surface smooth, cut surface not lobulated, looking like smooth, that's all. So this particular fatty change of the liver is seen over here under the microscope like lipid vacuoles. Now, this particular thing, if you tell us on the in the examination, I see lipid vacuoles, Daktur, in the fatty change within the hepatocytes. This is called fatty change, basically. So we'll not be asking you much in the metabolism, but of course, in your theoretical examination, there's a lot of questions based on it. So the lipid accumulates when the lipoprotein transport becomes deranged, totally disrupted, and at the same time, the fatty acids accumulate. So all these things you can see over here. Sorry, these things, this looking like a ring, right? Ring, the ring-shaped appearance. So these are the lipid vacuoles which are being accumulating in the hepatocytes. So liver cells are becoming enlarged. Basically, you can see this called clear vacuoles. I can ask you in the examination, what are these? You can say, doctor, this is very easy. Clear vacuoles appear in the cytoplasm, pushing the nucleus to the corner and giving a signet ring appearance. We need this only. These words we need in the examination to get to give you 20 out of 20 on the day of examination. So exam is very easy. Don't worry. My job is to tell you what is going to come in the examination, and it comes. So nothing more than that for the sake of examination. Again, the more important slide is the histopathological feature of the hepatocyte, macrovesicular. That is a little bigger, steatosis. So what do you mean by steatosis? Fatty change? This is an MCQ. Okay. This lipid accumulates in the hepatocytes as vacuoles, lipid vacuoles. I told you the lipoprotein mechanism becomes disrupted. These vacuoles have a clear cytoplasm which pushes the nucleus to the corner side, giving a signet ring appearance on H and E staining. It's called hepatoxylin eosin. Again, you can see now that this basically we finished with the fatty change. Is one of the slides which comes in the examination. The second slide which comes in the examination is the hepatitis, where we have seen the case number 5. Ibrahim case of the hepatitis. But what I'm trying to stress over here, why you call it itis? Itis is something called inflammation. Okay. Glossitis, inflammation of the tongue. Okay. Cellulitis, inflammation of the soft tissue, like that. Appendicitis, inflammation of the appendix. Okay. Gastritis, inflammation of the stomach, like that. Hepatitis, inflammation of the liver. So in viral hepatitis, we take a prototypical example with mononuclear inflammatory infiltrate. We call it mononuclear, means it can be lymphocyte or macrophage or a plasma cell. Okay, like that. So usually lymphocytes and plasma cells extend from the portal area and disrupt the limiting plate. I'll tell you what do you mean by limiting plate in my supplement of hepatocytes which are undergoing apoptosis. Apoptosis is a programmed cell death where individual hepatocytes are being eaten up. Eaten up means they're dying, okay, without much around inflammation, but they'll be picking up the inflammation, causing the cell death individually. Yusamma, programmed cell death of the so-called interphase hepatitis in the chronic active hepatitis. So what we had in the Ibrahim is a chronic non-active hepatitis yesterday in this case number 5. So you can see over here under the microscope, lot of this blue structures over here, small blue. So these are all the basically the mononuclear inflammatory cell infiltrates, mostly lymphocytes and plasma cells. So this is not normal in a hepatocyte. So this particular hepatocytes over here, you can see they look normal, but in between they are all these things are going, and I'll try to show you in my supplement how it breaks the limiting plate, how it causes interface hepatitis. All these istilahat should be understood very well. Okay, then we come to the microscopic level. Again, more higher power. Individual hepatocytes are affected by viral hepatitis. In viral hepatitis A, rarely leads to significant necrosis. So usually you have a fecal-oral, that area which comes and it comes in an active acute hepatitis. There is no significant necrosis, but hepatitis B can result in fulminant hepatitis. Now, this is very dangerous. Fulminant hepatitis, there's extensive necrosis. So the necrosis, as you can see over here, this area is becoming hazy, right? Hazy, this is hazy. And here you can see at least some outlines of the hepatocytes over here with a lot of inflammatory cells in between. All these blue cells are the inflammatory cells. I was telling my F13, F16 people, my students, that try to understand the disease at microscopic level. So what the other doctors think of the lesion, you people should be able to visualize or experience the lesion visually. Now you can, if you just think over here, these cells are all dying. You can see hazy nature, and you can see some outlines are maintained over here, and this will in future will die slowly. With extensive necrosis, you can see a large pink undergoing ballooning degeneration. You can see over here, this ballooning degeneration is going to happen over here, here also. You can see very clearly in this particular arrow, ballooning degeneration is seen below the right arrow. At the later stage, a dying hepatocyte is seen shrinking down in the concealment body. Okay, below the arrow, you can see this dying hepatocyte. This is called basically a concealment body. It's basically dying over here. You can see. So these are the dying hepatocytes in a fulminant with extensive necrosis of this one. So basically, we are trying to deal with the hepatitis, how the cells are being dying with around the inflammatory cells infiltrating the hepatocytes inside out and even in the in between the hepatocytes. So the third case which we have apart from the alcoholic liver disease and the viral hepatitis, we have liver cirrhosis. I'll try to teach you more in the supplement. It will become more clear to you. So liver cirrhosis, whenever you see, this is not a diagnosis. It's an end stage. End stage. See, end stage chronic liver disease characterized by four fundamental features. The disease will have a diffuse liver affection. Whole of the liver will be diffusely affected, and it will be affected and causes impairment of the liver synthetic functions. And you can see the consequences of the liver cirrhosis in the slides in future, which I'm going to focus. There will be diffuse injury of the hepatocytes causing necrosis of the liver cells. Okay, so liver cell degeneration occurs to a certain extent, forming liver regenerating nodules. So when it's called regeneration, they use some resolution. Resolution, as we have learned in the healing, it's coming to normality. Normality means coming to normal cells. But this is called regeneration and also resolution. But if it comes to the regeneration is lost, the resolution is lost, the collagen deposition occurs, called fibrosis, and all the disruption of the architecture of the entire liver occurs, and this fibrosis will slowly in future, if it extend to the whole diffusely the liver, it is called cirrhosis of liver, which is an end stage liver disease. Okay, in this you have to find some fibrotic bands, fibrotic bands, and that fibrotic bands are diagnostically, microscopically, and I'll try to give you some of the ideas such that you have a pictorial diagram in your brain. Okay, and you can just process that particular thing from the temporal lobe to the prefrontal cortex such that it remains in your brain. So what do you mean by stellate cells? They'll be asking you in the theory as well as in the practical. They are basically, you can see over here, the stellate cells. Can you see over here this area? Okay, they are perisinusoidal cells. There's a storage site of retinoids, that is the vitamin A metabolites, very important MCQs. They become activated in the liver disease. Now, this is again MCQ, secreted by TGF-beta. Okay, MCQ will come in this one. The one of the cytokines which secretes the stellate cells secrete TGF-beta, which helps to proliferate and produce fibrous tissue. Okay, and this is a major contributor for fibrosis, and subsequently it causes the formation of cirrhosis. This is a basically important slide which I've already given you in the PowerPoint. So what are the common causes of liver cirrhosis? So any disease that causes chronic long-standing liver cell injury and necrosis, it'll end up in an end-stage disease to some mass cirrhosis. There's a chronic process going on. Like, for example, if you don't treat the case of Ibrahim, slowly he'll develop into end-stage liver disease cirrhosis. You have seen the in the personal history or the family history of Ibrahim. There was his brother who was an alcoholic, and he died of the alcoholic liver disease. So he might have gone into cirrhosis of liver. So the most common cause of chronic, long-standing diseases is number one, just to remember, viral hepatitis, alcoholism, iron overload, and biliary obstruction. I'll try to give you some of the uh, pictorial diagrams on how to diagnose under the microscope, and as such that you remember the morphology, such that it will be very easy for you to understand the Robbins when you read the pathogenesis. Pathogenesis is a sequential step of formation of a disease. If you don't understand the pathogenesis, then you cannot treat a disease properly. You have to treat only the symptoms and signs. You are a doctor, you should treat the cause properly. Okay. So complications of liver cirrhosis, about 40% of the individuals with cirrhosis are asymptomatic, and this you should understand. The cardinal manifestations does not occur in 40% of the patients until late in the course of the disease. Whole of the synthetic functions goes down, and the patient comes to you with ascites or jaundice or whatever symptoms they have it in the form of encephalopathy. In advanced disease, symptoms and signs of hepatic failure are seen. The ultimate mechanism of death in most cirrhotic patients is progressive liver failure, causing the synthetic functions to go down. It can even cause coagulopathies and many more problems. Even the bleeding can occur. Complication related to the major complication is the increase in the portal hypertension. The portal venous pressure will increase and cause a lot of problems in the liver, which manifests in the form of cardinal manifestation. I'll teach you that 4 principles. And if you don't treat over a period of time, like I have seen many cases around 6 to 10 years from this area, they become hepatocellular carcinoma. Okay, basically, what do you mean by carcinoma? It is an epithelial malignancy. What do you mean by sarcoma? It is a connective tissue malignancy. So you should know these such basic terms. So complications of liver cirrhosis due to portal hypertension, we try to read that in the supplement. Ascites will develop. Why? There's increase in the hydrostatic pressure, decrease in the colloid osmotic pressure due to decrease in the protein building up by the liver hepatocytes. This causes the starting mechanism to become activated, so it causes high ascites. There'll be portosystemic shunts, like we have the esophageal varices bleeding or piles bleeding from the anus, and even you can have caput medusae around the umbilicus, as well as splenomegaly. And these are very important areas we got to understand. When you go to a hospital, you try to look these cardinal manifestations to confirm that there is portal hypertension. But you are a doctor not only to treat the disease, but you are a doctor to always to prevent the disease. Al-wiqayatu khairun min ilaj. So due to failure in the liver cell failure, the patient will have edema. I told you increase in hydrostatic pressure. It will be generalized edema in the whole body. Yusamma anasarka. What do you call it? Sometimes called anasarka. Anasarka. That is generalized edema. Okay. And you have ascites in the pleural edema in the peritoneal area, pleural effusion edema in the pleural area, and leg swelling edema in the leg area, and hepatic encephalopathy. The toxic substances cannot be metabolized, goes to the brain, causes hepatic encephalopathy, and slowly you develop over a period of 6 to 10 years the hepatic carcinoma, Yusamma hepatocellular carcinoma. Okay. We have this third slide. It's called cirrhosis of liver. They will give you this one. If I'm sitting in an examination, I'll tell you to explain this. You can tell doctor this is nothing but a macronodular cirrhosis, usually caused in the form of vitamin B or C, long-standing. And one of the commonest causes of macronodular cirrhosis is B and C hepatitis. And micronodular cirrhosis, common causes alcohol, Wilson's disease, and alpha-1 antitrypsin deficiency also has to be remembered by you, can also produce macronodular cirrhosis. So I remember last year I was asking some people these 2 diseases and I gave them full marks. Inshallah, I'll give to you also. If you don't tell, I'll give you. If you tell this only, I'll give you the full marks. Don't worry. So this is micronodular cirrhosis. You can see all this area, small. These are micronodular cirrhosis. These nodules are less than 3 millimeters, and the common cause is chronic alcoholism. So micronodular is alcoholism, okay, and the macronodular big nodules, common is viral hepatitis. Apart from that, I just told you just now, is Wilson disease and alpha-1 antitrypsin, okay. This is like an example of micronodular cirrhosis. You can see the greasy yellowish hue indicating the fatty change, also called fatty change of alcoholism is present over here. So these are very easy for the examination. You can see the micronodular, if you make it more high power, a close-up view of the micronodular cirrhosis is liver with the fatty chain demonstrate the small yellow nodules for you to examine. This micronodular cirrhosis may also be seen, as I told you, in Wilson disease, primary biliary cirrhosis, and even the hemochromatosis. And we have, mashallah, in this batch, very good students. I am teaching only F13 and F16, and I see very intelligent students who actually come prepared. Now we go to the same cirrhosis of liver under the microscope, the histopathology slides. You can see this underlined, this dashed area. Sorry, this area. Okay, this area actually, this particular area. Got to know what you mean by this one and this area. You can see this area and this area. I mean this area. All these fibrous bands. Now this microscopically, this called this particular area, this whole of this one, even this one, are the Usama regenerative nodules of hepatocytes surrounded by all this fibrous tract or fibrous connective tissue made up of collagen. Okay, made of collagen and fibrous connective tissue, where the stellate cells help them to make it bridges between the portal tracts. Now, all this architecture is totally distorted with the collagenous tissue are scattered in between. You can see some of the, if you make it high power, you can see some lymphocytes in between, as well as you can see small proliferation of the bile ducts. So at your level, you can see in this particular regenerative nodule, I'll just make it, you can see, basically this is the regenerative nodule, and these are all the fibrous tracts. And here you can see the fatty chain inside. So this is a micronodular cirrhosis seen along the moderately fatty change. We call it macrovascular chain steatosis. So the two most important characteristic microscopic features are the regenerative nodule. I'll ask you, what do you see over here? This is the regenerative nodule. And what do you see outside? Fibrous connective tissue, full marks. Don't worry, 20 out of 20. Okay, extending between the portal regions and surround the nodules. So I'm taking some time for you such that you don't have to waste much time to read this particular PowerPoint. You keep it for your practical examination. Read it one day before, that's enough for you. So this, I just put it as a gold standard liver biopsy, obtained either by a percutaneous or an ultrasound guided fine needle aspiration. You have to go and learn in the King Fahd Hospital. Those people are very good and they give you. So actually what they do is they would do a staging F1, F2, F3, F4 cirrhosis. Accordingly, there's a protocol of treatment, what they give it with the interferons and inflammatory activity A1, A2, A3, and accordingly they give some of the interferons according to the staging. We call it metabolic scores. This can be useful for you in the SMLE examinations. Okay, biopsy is not necessary if clinical, laboratory, as well as radiological data strongly suggest presence of liver cirrhosis, but usually we do it in Kingdom of Saudi Arabia. Okay, I think this is one of the last slides, but afterwards I'll give you a supplement, I think, where you can just listen to me and enjoy. Okay, cirrhosis, the diagnosis gold standard, always the liver biopsy. Okay. Not required if the diagnosis is clear from the history. Done when biopsy will change the management. So imaging, ultrasound, CT and MRI can be done, show small nodular liver, that is the cirrhosis, can be seen very in the early stages by a CT scan, especially more sensitive or specific for the diagnosis, more helpful for detection of the hepatocellular carcinoma. So if you have an hepatocellular carcinoma, I think CT scan is very useful, and even you can go and see the metastases in the jism. Clinical diagnosis is made commonly by presence of ascites. Already there's a portal hypertension going on in the body, so we can easily make it out. Low platelet count because all the platelets are being consumed by the spleen. We call it hypersplenism. I will try to teach you. Spider angiomata will occur because the pre-encephalopathy will occur and cause a spider angiomata. All these things are due to derangement of the coagulation factor. So in the form of bleeding, they come clinically as a cardiac manifestation called spider angiomata. Okay. In conclusion, conventional ultrasound cannot differentiate accurately the different liver fibrosis stage. So most of the time you got to do a biopsy. Okay. And newer ultrasound stage, you some elastography. One of my friends in India is expert of this one. You can actually stage it in the elastography. You go on to see the amount of fibrosis under the electron microscope. So there are 4 elastography techniques called transient elastography, real-time elastography, acoustic force impulse imaging, and shear wave elastography. This will not come in the examination for you, just for your knowledge sake. No, there's a supplement for you all, not for practical examination. This is additional material for better understanding of the case of Ibrahim and the liver diseases. It's just a supplement where you don't have to even, if you don't want to listen, don't listen it, but it will be useful for you. I'll try to finish this in 10 to 15 minutes or maybe 20 minutes, less than that. Now you got to know what you mean by this portal tract. I just was telling you the portal tract has the bile duct, portal vein, and hepatic artery. I told you this is the limiting plate. Okay, now this is the portal tract and this is the limiting plate. And you can see over here, there are no inflammatory cells. There'll be some inflammatory cells normally over here. Suppose the inflammatory cells are crossing this one, it causes a major problem. Okay, now that has a some limiting plate. This limiting plate, why I'm telling you is when you read the articles, when you read the book, you should know what do you mean by these definitions. So this is important histologically in inflammation extending beyond the limiting plate is important to note down. Okay, number 1 slide. Number 2, the microscopic liver anatomy has to be understood very well. As I already told you, what do you mean by zone 1, zone 2, and zone 3? Zone 3 is near the central vein. Okay, now you can see the blood flow, how it is flowing in this area, and the bile flowing in this area has to be understood. As I told you, portal tract is here over here, and zone 1, zone 2, I already told you about the freshest blood, and the zone 3, the poorest blood with oxygen. So this particular unit has to be understood as a definition in your mind pictographically, such that don't get confused. You should always remember the bile duct, the hepatic artery, and the portal vein, such that when you read the textbook or the PubMed articles, it becomes easy to understand the canalicular system, spaces between the portal tract. Okay. And this again, a slide which is very important. Under the microscope, you can see over here, this is basically a vein where here you can see the blood from the portal tract going toward the vein, and the bile is going from this direction, has to be understood. And these you can see the hexagonal appearance of the portal lobules. Very, very important to understand. Okay. Now this is again a lobular architecture. As I told you before, the hepatocytes are arranged in thin plates and cords. The people feel that these particular 2 or 3 some neoplastic tissues taking place. No, this is normal. All these hepatocytes are normal. And you can see this white area, they're called sinusoidal spaces lined by the endothelial cells filled with blood, and the Kupffer cells, the form of reticulo endothelial system cells, and of course the stellate cells which form the collagenous tissue. Kupffer cells are the liver macrophages, which are very important to understand. Stellate cells are important to make the collagenous tissue in the form of fibrous tissue. There are also pluripotent stem cells of the liver in that area. Bile is excreted from the hepatocytes into the bile canalicula, which is being picked up by the canals of the herring and being stored in the gallbladder. And the time when the digestion of the fat occurs, it is being released at the point of ampulla of Vater in the second part of duodenum. You people know it. It's just a basic thing. So what do you mean by portal hepatitis interface? So you can see over here this on the left side of your screen. Sorry. Okay, this one, the portal inflammation on the portal tract. You can see this line. You can still see the demarcation between the inflammation ends and the hepatocyte begins. So these are the hepatocyte area which begins. No inflammation over here, but this area has a lot of inflammation. So no interface activity on the right. Inflammation is contained to the only the portal tract. But here it is broken. It comes from the portal tract to the liver hepatocytes. It's called interface hepatitis. Now, this is actually the terms used in the in your textbooks as well as your PubMed articles. You can have both you can have both or just portal hepatitis or interface hepatitis, just to know a pictorial demarcation in your brain, such that you can utilize it from your prefrontal cortex whenever necessary. Now you can see the balloon cells with Mallory bodies, especially in the Mallory and Hyrin bodies, especially at the level of alcoholism. Okay, so you can see the balloon cells on the left side, markedly enlarged hepatocytes with cytoskeletal elements. They start clumping over here. You can see they form clumping over here, and it becomes ubiquitinated to go for the apoptosis, as well as it becomes decrease in size for the atrophy. So Hyrin and intermediate filaments. Now this particular area, I'm just underlining, this will come in the examination as an MCQ. Please remember the Mallory-Hylian bodies in the alcoholic liver disease. What are they? They're the intermediate filaments. When I wrote SMLE, this question came. What are those Mallory-Hylian bodies? They are the intermediate filaments. Okay, like this, questions do come up. And on the right side, you can see the acidophilic body, pycnotic nucleus. You can see over here very clearly. Sorry, here very clearly. Condensed chromatin, hyperchromatic eosinophilic cytoplasm becoming small. Now these are the cells which are becoming apoptotic bodies called acidophilic cells and concealment bodies. These are the things you should know to understand. What do you mean by cholestasis? Now you should know what do you mean by cholestasis. Hepatocytes form bile. If something happens to either interrupt the excretion into the canalicular spaces or the flow of the bile through the biliary system, you'll see the pooling of the bile at spaces, eusamma cholestasis. So plugs of bile within the canalicular space again is called cholestasis as a eusamma canalicular stasis, cholestasis, and we should know it. What do you mean by hepatocellular cholestasis? Here you can see intracellular bile accumulation. Inside the hepatocyte, you can see bile. Inside the sinusoid is eusamma canalicular. So this is the accumulation of the bile either in the canal or in the hepatocyte. It's called cholestasis. Okay, we have a lot of patterns of hepatocyte injury. Okay, dividing up what do you mean by hepatocyte injury? Like cell death, we call it hepatocytes, degenerative or intracellular. Because now this is not for your, this is not a proper official lecture to you, but I'm just giving you because students like to listen. Last year also I gave it. Now this will be useful for you to understand. There are doctors who are going to take the lectures in detail, viral hepatitis, all such thing. They'll tell more than me. What do you mean by apoptosis? What do you mean by ballooning degeneration? I told you what do you mean by steatosis. There's fatty accumulation. What do you mean by inflammation causing influx of acute and chronic inflammatory cells in the portal tract or in the interface or in the lobules should be understood very clearly. So this is called hepatocyte injury. You should know the patterns of injury. What do you mean by bile injury? I just told you the cholestasis, accumulation of bile in the hepatocytes or in the canals. Okay. Structural versus the function. Then you should know what do you mean by hepatocyte and biliary injury resulting from ischemia. Then we just read about the regeneration, nodules, and the fibrosis. So these are basically the patterns of hepatic injury given in the books and the PubMed articles, dividing the injury pattern into different types. Can have a combination, can have one or two or three. You can only have one and causing the regenerative nodules and finally into a fibrous band causing the cirrhosis of liver. We have serum markers. We have just seen in our study. What do you mean by AST? What do you mean by ALT? That indicates hepatocyte integrity. If these are increased, that means there is a cell injury. I was telling my students that day, when there is a serum bilirubin increase, that the substances secreted in the bile is totally disturbed. If it is unconjugated, the total bilirubin will be more. If a direct is conjugated, bilirubin will be more. The bile canalicular system is affected. If it is unconjugated bilirubin, then the hepatocyte injury has occurred. So you should know the conjugated causing the bile canalicular system to be deficient and the unconjugated bilirubin where the hepatocytes have been injured. You should know why there is serum alkaline phosphatase increase causing the synthetic enzyme, membrane enzyme being affected, and the serum gamma glutamyl transpeptidase. This is called biliary function integrity, hepatocyte integrity, and the third is the secreted protein, that is the hepatocyte function. Is that when the injury is there, the serum bilirubin is not produced, it becomes decreased. Prothrombin time increases due to non-production of the coagulation factors. The PT time will be increased, causing bleeding. Hepatocyte metabolism, when the hepatocyte becomes injured and the serum ammonia is increased and it goes into the brain, causing hepatic encephalopathy, psychological changes. And these are the cardinal manifestations which I'm trying to explain to you in this particular slide. So we have just seen in Ibrahim case of the viral hepatitis, most commonly caused by the hepatitis B or C. Okay, others can occur, no problem. Autoimmune, some of my students have discussed this one. Toxic injury like alcohol, metabolic injury like non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. Another name of NAFLD is called NASH, non-alcoholic steatohepatitis. Okay, it's a metabolic syndrome usually composed in the obesity, the growing topic Lot of data update is there on the PubMed. So intracellular deposition like hemochromatosis, alpha-1 antitrypsin, Wilson disease, metabolic. This all I'm teaching is not for the examination. It's only to develop interest in you to understand the textbooks. We are not going to details. All these viral hepatitis, like we have seen the hepatitis A, B, C, D, and E. Even the Epstein-Barr virus will cause viral hepatitis. Cytomegalovirus, lot of MCQs will come in your SMLE, herpes simplex virus, and the adenovirus. All these should be read very clearly. Clinical syndromes which come into you when you go to the 4th year, 5th year, and 6th year. Somebody will say, oh, Dr. Jomana or Dr. Batulsi, there is acute hepatitis. What do you mean by that acute hepatitis? You should try to understand what type of injury is there. Is the hepatocytes are being integrity is maintained or not? Acute hepatitis with symptoms or asymptomatic should be understood very clearly. When asymptomatic, you have to see the lab reports. Symptomatic, you can come. Okay, chronic hepatitis, we had this case. Ibrahim, the chronic, the relapsing or remitting, is this patient on treatment or not, or continuously relapsing for more than 6 months? Very important. Hallmark of the hepatitis C virus. What do you mean by fulminant hepatitis? This progression to hepatic failure within 2 to 3 weeks. Or the patient presents acutely ill, doesn't able to walk properly, comes on a stretcher, comes to the Tawari, they need a liver transplantation in most probably. In the United States, most commonly it is caused by hepatitis A and B. Okay, very important. You should know it. Hepatitis A or B. Carrier state, we have in this particular Ibrahim case, harboring replicating virus that can transmit the organism. So it's very important to understand shedding of the organism. Okay. Now, this is basically the acute hepatitis. I just want to know the difference in the chronic hepatitis, which lasts more than 6 months. This is very, very important. You can see the lymphoid aggregates bridging necrosis from the central vein to the portal tract. This particular thing occurs in the chronic hepatitis. There will be periportal necrosis as compared to the acute hepatitis. There's only bile duct reaction, lot of inflammation as compared to the chronic hepatitis. You can see a lot of inflammatory cells, periportal necrosis here. The periportal fibrosis occurs over here in the chronic hepatitis. This is a very good schematic representation. I'm trying to show you. All these things, the macrophages aggregate will be more proliferating as compared to the chronic hepatitis. Macrophages will be going and trying to change. You can sometimes see the fatty change in hepatitis C also. Okay, hepatitis B, I'm going to tell in detail. The most important thing is the ground glass appearance in hepatitis B, which is going to come in the examination as MCQ. Very important. There's a immunohistochemistry of the HBsAg. This is called surface envelope. It becomes positive for the immunohistochemistry, and even the core antigen becomes positive. So we have got to see in what stage the hepatitis B is going. It is subclinical, or is it the chronic hepatitis, or it produces the healthy carrier state. We have to be very careful in giving the advice to the patients, and at the microscopic levels, we have this ground glass appearance of virions. Okay, we have hepatitis C, where you can see the lymphoid follicle over here very clearly in the hepatocyte area. Major cause of the liver disease. It's still a major cause in the whole world. Higher rate of progression to chronic hepatitis, and this is an MCQ which comes in the examination. 80 to 85% of the hepatitis go for what do you call it? Chronic stage. You can see at this stage the portal inflammation. I taught you the interface inflammation, and in the lobular hepatitis. All these things are clearly seen in this one. So you can see over here, it breaks the portal tract. It goes to interface. It goes to the whole lobular, especially in the hepatitis C. And you can see even the steatosis. Sometimes you can see, lipid vacuoles coming up. The various subtypes do occur. Multiple strains can be seen. Try to read the textbook. Okay, alcoholic related injury, I told you, is again very important. Like alcoholic abuse is so common in the whole world. Now, in this particular thing, what the MCQ comes in the examination, AST is a mitochondrial enzyme more than the ALT is a cause of the alcoholic related injury. Now, it's very, very important to understand this particular thing. Now, this will come in the examination as an MCQ. I was just telling you this is the normal liver causing the severe exposure, abstinence occurs, and there's a fatty change over here. Over a period of time, the liver cell necrosis occurs, and slowly you can see over a period of time, 10 to 15% of the cases, the liver cell from the liver will cause alcoholic liver cell cirrhosis. So the three distinct patterns which occur in the alcoholic is the steatosis, that is a fatty change. Okay. Then the hepatitis with lot of inflammatory cells crossing the limiting plate as well as the portal tract. And finally, the cirrhosis. So please remember these three terms: steatosis, then comes the hepatitis, the alcoholic hepatitis, then comes the cirrhosis. So this we take it as a prototypical examination to understand the alcoholic liver. Okay. Then we have a NAFLD, which is quite becoming very famous in the whole world. Non-alcoholic fatty liver disease, also called NASH, that is the non-alcoholic steatohepatitis. Has to be understood and try to read this, the macrovesicular steatohepatitis. The other causes are, for the examination point of view in the MCQ, will be obesity, hyperlipidemia, hypertension, insulin resistance are one of the commonest causing the metabolic syndrome of NAFLD. Okay. Now, just as a very important symptom of liver disease, you can see the yellowish discoloration of the skin, earliest sign in the scleral cortex. We have got to be very, very clear in this area to understand this particular thing. So I was just trying to not to overstress. Now, what do you mean by jaundice? It is an increase in serum bilirubin, basically more than 2.5 milligram per deciliter. Okay, arises due to disturbance in the bilirubin metabolism. I'll just try to give you a little overview of it. Now you can see the sclera over here, yellow sclera, yellowish. This is called jaundice. Now I just want to stress over here that you people should read very well. Go to the biochemical book of anything, whatever you have. Try to understand what do you mean by bilirubin metabolism. I'll try to give you a very small overview of it such that you should never forget it. Okay, what is happening over here? What causes basically the jaundice? I'll just try to keep it over here. So what is happening? The RBCs after 120 days they will die. So this dying RBCs will be picked up by the reticuloendothelial system. That is the macrophages. Okay, you should know this. So macrophages will present it to the spleen. Okay, and the spleen will go, and so the macrophages will be taken up by the RBC, dying RBC taken up by the macrophages and goes to the spleen, where in the spleen all these macrophages are being consumed and the RBCs are being consumed. Now, when the RBCs are being consumed, what is happening? The hemoglobin comes out. So hemoglobin contains heme and globin. You should know this, very important to understand. Okay. Now, heme contains the iron portion and the protoporphyrin. You should know this. Okay. And globin contains, it is broken down to amino acids, and this is recycled. Nothing to worry. It is recycled. Okay. I'll go to another page such that you understand. Now, what is happening in this area? Now, here we have the heme, right? I told you this is the heme. This is the iron. This is also recycled, taken up. So nothing to worry. Okay. Now we have this protoporphyrin. Okay. Now this is goes to form the unconjugated bilirubin. Okay. Now this taken by the albumin in the serum. That takes up the albumin in the serum. So now this is actually delivered to the liver. That is very, very important to understand. This is delivered to the liver. Liver cells will conjugate this unconjugated bilirubin. They try to conjugate it. I'll go to another page such that, so liver, what does the liver do? Liver will try to conjugate. Okay. The bilirubin, they try to conjugate the bilirubin and will try to dump in the bile canaliculi. You should know this. Okay. So the bile ducts. So all this dump and all these things will be taken up by the bile ducts, and the bile is formed and it's being stored in the gallbladder. And whenever necessary, the gallbladder will secrete the bile into the use for whenever there's digestion of the fat is necessary. It goes into the second part of the duodenum through the ampulla of Vater it's being utilized. So bile it goes to the duodenum and then it picked up by the intestinal flora. The conjugated bilirubin is made into urobilinogen. Remember, okay, urobilinogen. This is very, very important to understand what is basically happening. So we came to the urobilinogen. So it makes the stool brown, okay, partially reabsorbed into the blood and filtered by the kidney, making the urine yellow. And this is very important. Okay. Now, what is happening is this basically the bilirubin metabolism. I'm not going to teach you this one. I just leave it for you to understand at home, and you can just see. I'll give it to Hadil, and you can just take it up. Now, for example, I just tell you diseases. Extravascular hemolysis will cause, or ineffective erythropoiesis will cause unconjugated bilirubin to increase, causing the find of jaundice. What will happen over here? The clinical features are very clearly the urobilinogen increases, so it causes dark urine. You have a physiological jaundice of the newborn, where the increase in unconjugated bilirubin will with this specifically causing connectors, which actually goes and colors the basal ganglia. Treatment is very easy, phototherapy. Gilbert syndrome, again, increase in unconjugated bilirubin, and Crigler-Najjar also unconjugated bilirubin. All this causes the serious infection and connectors, and also the Dubin-Johnson syndrome. Now, remember these 4 points, they come so much in the SMLE. Remember, okay? These 4 words: physiological jaundice of the newborn, Gilbert syndrome, Crigler-Najjar, Dubin-Johnson. You can just see the etiology and the clinical features. Now I'm coming to obstructive jaundice, which is very important. Now these are associated with the affecting the bile canaliculi, like the gallstones, pancreatic carcinomas, cholangiocarcinomas, the parasites, Clophalia, the liver fluke, all such things. So here the conjugated bilirubin is increased as compared to unconjugated. Only conjugated in this thing is the Dubin Johnson, and this is the MCQ, very favorite area. Okay. Now here the dark urine due to bilirubinuria in biliary tract obstruction, and the stools will be pale. You can see over the pale stools, lot of pruritus, and plasma bile acids will be increased, hypercholesterolemia, and you can see a lot of xanthomas on the body. Then the patient will come with steatorrhea and malabsorption of the fat-soluble vitamins, that is the A, D, E, and K. Now, this is actually very important for you to understand. Of course, we'll be dealing with the viral hepatitis. I'm not teaching you, but I'm telling you it increase in both the conjugated as well as the unconjugated. This is the highlight of this slide, okay? And cause dark urine in the urine, urobilinogen will increase and will cause something. So this, go and read it very easily. So I'm trying to tell you the inflammation of the liver parenchyma eusamma. Viral hepatitis usually by the hepatitis virus, which I've already showed you, hepatitis A, B, C, E, and D. Okay. Apart from that, question will come from the Epstein-Barr virus and the cytomegalovirus. So viruses cause acute hepatitis and chronic hepatitis, as we have seen in the Ibrahim case. Acute hepatitis means there's a mixed conjugated bilirubinuria and the unconjugated with dark urine. Remember, this is very important as a clinical scenario. Okay. I'm just giving you important guidelines for you to pick up and read the book as well as the articles. Okay. Which causes fever, malaise, and nausea. So elevated liver enzymes, especially the ALT, will be more than the AST, specifically in the acute hepatitis, and the symptoms are less than 6 months. If it is more than 6 months, the eusamma chronic hepatitis. Remember, okay? And we can see over here the acute hepatitis, lot of inflammatory cells are blue, and even affecting the canaliculi as well as the hepatocytes very clearly. Chronic hepatitis definition, more than 6 months symptoms, risk of progression to the cirrhosis, very important. Okay. You can see over here, whole of the portal tract is, sorry. You can see this area, whole of the portal tract is affected. And even it is breaking the limiting plate. I told you the limiting plate, breaking and going to the hepatocytes. You can see over here. Okay. So there is interface hepatitis, the bridging of necrosis will occur. And if you go down, they will have some sort of fibrosis. Okay. Now this I'm not going to go into details, but very important is to know the hepatitis A and E together. You can read this, understand the comments. Now our importance is over here. the very, very important hepatitis B, the parental transmission through the childbirth, unprotected intercourse. We have discussed so much in our batches with how does, what do you mean by unprotected intercourse and intravenous drug abuse? How does it cause acute hepatitis? How does the disease become 20% chronic in hepatitis B virus? And this is an MCQ which comes as compared to hepatitis C. There is results in acute hepatitis. Chronic disease occurs in most cases, up to 80%. So again, a parental transmission do occur, and you can see again an unprotected intercourse, needle stick injury, and the risk from the transfusion. Mashallah, Saudi Arabia has done a lot of work on the transfusion screening, and they have done it. So HCV RNA in our case of Ibrahim was increased, confirms the infection, and RNA levels indicate recovery, persistence, and accordingly we can follow up the case. Okay, hepatitis D, you go and read it nicely, nothing to worry. Now this is the hepatitis B. We can see all these cells of hepatitis B very clearly as compared to the ground glass. We call it ground glass appearance of the hepatitis B. As compared to the hepatitis C, we have a lymphoid nodule. Lymphoid nodule in the hepatocytes. Okay, hepatitis C. And this basically the chronic hepatitis. You can see the bridging necrosis. It bridges and causes and crosses and causes the spotty, focal spotty necrosis, confluent necrosis. All this area will become necrose. This is the classically spotty necrosis and the bridging necrosis. They cross the limiting plate and goes into the hepatocellular area. We call it after the limiting plate goes to the portal, from the portal hepatitis to the hepatocyte injury occurs there. Now, this is actually very easy to understand. Nothing. If you give an immunization, I'll start from here. You will have the IgG protective in the form of this one. Okay. So if you do a test for that immunize, you'll get this IgG positive. Okay. But if you do an acute, if you have an acute stage of hepatitis, okay. Now, what is the most important is the envelope. When you want to give gift to your friend, you give the money in the envelope, right? So you're transmitting something from your money, from your pocket to another friend's pocket through the envelope. So this is a communicable, infectious. Okay, remember. Sorry. This was infectious, right? This was infectious, and this was negative in Ibrahim case. Okay, I remember. So what is happening is the first serological marker or the HBV DNA. This will become like that. Okay. And if you do for the core antibody, IgM will be present. And it was there. Now the window phase, we don't have HBsAg, we don't have HBeAg, only IgM you have to see for the window phase. So a lot of MCQs, inshallah, if I have a chance, I was just telling, I'll just pick a few of the around 20-25 MCQs. It's like mathematics, we can solve all the cases in future after we finish the nutrition metabolism module. Okay, then we have this resolved one. Totally resolved. We have this IgG protective like this one. But here was our case yesterday. The chronic, more than 6 months of defines the chronic state. So HBe can be present or absent, but presence of HBeAg indicates infectious, or HBV DNA indicates infection, indicates infectivity. Now, IgG is usually immunoglobulin to the core antigen is present. But the problem in our case, Ibrahim, they did not give us the HBsAg. But we made out that this is a chronic case. Usually it becomes positive. That's all. Nothing to discuss. And inshallah, when you have any doubts, you read your textbook. Just give me a photograph of what you don't understand and try to mark it. I'll try to explain you through the voice message. Okay. Cirrhosis is basically the end stage liver disease for all the, this is the liver end stage before dying, disruption of the normal hepatic parenchyma by bands of fibrosis and regenerative nodules. I've shown you before, like all the small nodules you have seen over here in the previous case. And you can see over here, all these fibrous bands. You can see the fibrous bands. And this is the regenerative nodule. You can see the regenerative nodules. You can see the regenerative nodules. You can see the regenerative nodules very clearly. Okay. Well, I told you about the stellate cells. These are the cells mediated by the TGF beta, which comes in the examination, lying beneath the endothelial cells in the sinusoids. You can see there is a trichome stain, which indicate the fibrosis. You can see all this area stained, and this is the, and these are the regenerative nodules of the cirrhosis of liver. So this is the alcoholic liver disease, which can cause cirrhosis, liver cancer, upper GI bleeding, hepatic encephalopathy, sarcopenia, osteoporosis, cardiovascular disease like that. Complications is very important. You have to know that the portal vein will be hypertensive, causing gastroesophageal varices at the level of the esophagus and the stomach, portal hypertensive gastropathy causing bleeding, splenomegaly, which can cause hypersplenism, eating up of the RBCs and the platelets. They are all consumed basically. Then we have the hydrostatic pressure increasing, causing ascites and spontaneous bacterial peritonitis. This is very dangerous if they develop it. Even patient will develop hepatorenal syndrome, and the ammonia will cross the blood-brain barrier, causing hepatic encephalopathy. Then the patient will be affected in the pulmonary area called hepatopulmonary syndrome, and the coagulopathies occur causing bleeding, fibrolysis, thrombocytopenia, osteopenia, osteoporosis, osteomalacia, because all the liver synthetic functions goes down. Hematological abnormalities like anemia, hemolysis, thrombocytopenia, neutropenia occurs, and cirrhotic sarcopenia, malnutrition, and slowly, over a period of time, you have a cardiomyopathy called cirrhotic cardiomyopathy. Now, this you got to go and read in the book. What do you mean by hypertension? The increase of more than 5 millimeters of the hepatic venous gradient pressure. Okay, normal is 3 to 5 millimeters. This is MCQ, which comes in the examination. The wedge hepatic venous pressure will minus the free hepatic venous pressure will give you around 5. So it's a measure of the portal sinusoidal pressure, is obtained by catheterization, cannot be detected by any non-invasive technique. It's an invasive technique via hepatic vein, via jugular or femoral vein. So this indicate the clinical features come as gastroesophageal varices in the form of bleeding and hemorrhage, ascites causing increased hydrostatic pressure, decreased colloid osmotic pressure, and hypersplenism causing consumption of the RBCs and platelets, variceal bleeding, immediate life-threatening problem, 20 to 30% mortality, people will die associated with esophageal varices, and even the patient will have piles. We call it bawasir in Arabic, and the portal hypertension. These 4 symptoms we got to, or clinical manifestations: ascites, congestive splenomegaly in the form of consumption of RBCs and platelets, portosystemic shunts in the form of esophageal varices, piles, caput medusae, all such things do occur, and the hepatorenal syndrome. Okay, the detoxification decreases in cirrhosis, causing mental changes. Ammonia goes up, asterexis, that flapping tremor occurs, coma, and gynecomastia, spider angiomata in the form of bleeding, spider angioma, palmar erythema, of course, the jaundice I told you in detail. Decreased protein synthesis causing hypoalbuminemia, and whole of the body will go into anasarca, and coagulopathy will go into bleeding. Okay, you got to know this, and anasarca. All you can see patients going into high whole body edema. Alcoholic liver disease has caused the consumption of alcohol, hepatic parenchymal damage, most common cause of liver disease in the West. You can see over here all this mechanism where you can find a signaling appearance of the lipid vacuole disrupting the lipoprotein mechanism. You can see a greasy, yellowish hue of the enlarged hepatomegaly of the alcoholic liver disease. You can see at the ultrasound, this is the normal liver, but the echo texture is increased over here in the fatty liver, echo texture. Okay. And in the CT scan, you can see enhanced CT, the comparison of the normal liver with the fatty liver. You can see increased liver and spleen attenuation. You should use these terms. And fatty liver can be diagnosed on contrast enhanced CT if absolute attenuation is less than 40 HU units. You can see the fatty liver, posterior sound attenuation, enlarged liver. You can see all this enlarged area with a heavy, fine, homogeneous echo texture. Echo texture, these terms has to be used by you. Why I'm telling you this is you should get familiar with the terminologies. Alcoholic hepatitis causes chemical injury to hepatocytes, especially in the binge drinking. Acetaldehydes damages the whole liver, and you can see over here, and you can see the mallory-hydrin bodies very clearly over here. Okay, the presentation in alcoholic liver disease, the painful hepatomegaly, elevated AST more than the ALT, and this is a very important MCQ coming in the examination because this is an mitochondrial enzyme may result in death. Cirrhosis, complication of the chronic alcoholic liver cell induced most commonly, and 10 to 20% of the alcoholics go into cirrhosis. Okay, NAFLD, as I'm telling you, fatty change, hepatitis, and cirrhosis, and develop without exposure to alcohol can be many other causes. Usually in our setup is obesity. Okay, and here the ALT more than AST. Remember, go back. AST more than ALT is alcohol. Remember. Okay, come here. ALT more than AST is non-alcoholic fatty liver disease or non-alcoholic steatohepatitis, NASH. Okay, now this is basically the different stages of healthy liver to the fatty liver to the liver cirrhosis, fat liver fibrosis, then you have a liver cirrhosis. So that's all. I think I've done a little job for you. So you go and read the textbook nicely. A practical examination is a little easier for you. Nothing to worry. I think you people have heard it nicely. And if there is any questions, you can ask me in the WhatsApp. I'll try to give this to Hadil. Inshallah, she can send it to you. Thank you so much. Anything you want to make a comment or somebody want to make a comment?
Doctor, you'll send us the even the additional slides, right?
Yeah, I'll do that. Don't worry.
Yeah, okay.
Because this is only for your understanding, nothing for the examination. My job was to give only the practical pathology, which I have given the starting, and it's very easy to score all 20 out of 20. Don't worry about that one, but try to understand the disease, try to understand the Ibrahim case, try to be more practical in your second session, and it will be more interesting. Jazakumullah khair. So nice of you. I'll just say it to you, Hadil. Okay. Barakallahu fikum. Assalamu alaikum.